I'll be discussing from my perspective who needs an IVC filter in 2019. These are my disclosures. And I'll start with a figure that kind of captures what Vivian started out to say, which is the nationwide utilization of IVC filter use in the US. And this was really growing, IVC filter placement on the bottom here and rate of VTE hospitalizations on the top line here, up until the point of that FDA advisory release in about 2010. After which, thankfully, the use of IVC filters did decline a bit following this, and this was not because there were a lower rate of VTE hospitalizations, it was because truly the providers were being a bit more discerning in terms of who should get an IVC filter appropriately. And the reason for this is, as was alluded to in the last session, the last talk, the risk is high. So this is taken from an ad. I just Googled IVC filter and this image came up. Complications can include things like device migration, thrombosis, fracture, perforation of the IVC, and difficulty removing the device if it's left in too long. And it turns out when we look at nationwide samples, we don't do all that well in terms of removing IVC filters. So this data comes from national insurance claims between 2010 and 2014 of over 50,000 patients. The indications for IVC filter placement are listed here, including nearly 1/5 of patients who did not have an active venous thromboembolism, so assuming it was prophylactic use. And over a year of follow-up, the retrieval rate was not all that good. Taking all patients together, it was, which is this black line here, it was barely 20% retrieval. Most people would believe that their rates are better than this, but as Dr. Desai was saying yesterday, you should challenge yourself with that and take a look at your own numbers in your own institution. So what do the guidelines actually tell us? As Dr. Boucher was saying, there's no dispute among the different societies that patients that have a contraindication to anticoagulation should have an IVC filter placed if they have an active thrombosis, and that you should restart the anticoagulation as soon as you can and get the filter out. After that, things start to get a little bit more murky. Most societies agree it shouldn't be used routinely as an adjunct to the other therapies that we have available, including systemic thrombolysis. But in patients with poor cardiopulmonary reserve, there's a little bit of lack of clarity here, and I'm going to delve into the evidence for this a little bit more. So you heard about the PREPIC 1 study with permanent filters. I'm going to spend a little bit of time on PREPIC 2, which was the Retrievable filter study, the only randomized control trial that we have available to try to answer this question. It included just short of 400 patients with acute PE, DVT, or superficial vein thrombosis, and one high-risk criteria, which is listed there for you. And patients were excluded if they had received 72 hours of anticoagulation before randomization, and then they were randomized to either have the filter with anticoagulation or anticoagulation alone for 3 months with filter retrieval at 3 months. And these are the risk factor patient characteristics across the two groups. And I would actually say that I think this study did a pretty good job of capturing the type of patient that you previously might have considered putting in a filter. So patients with prior VTE were about 35%, unprovoked patients 3/4, at least one sign of RV dysfunction, so potentially submassive patients, about 2/3 of the population. Older patients, active cancer, even including a small amount of those with ileocaval DVT. And despite this, what they found at both 3 months and 6 months was there was no difference between recurrent pulmonary embolism or fatal pulmonary embolism between the two groups. Now, perhaps they had a lower risk of the higher risk patient with RV dysfunction. So we don't have randomized data, but I thought that this was a very interesting study. This was done by Stein in 2012, looking at the use of IVC filters in patients with low reserve. So it was a retrospective analysis of over 2 million patients across the US to try to determine who would benefit from IVC filter placement. And they used ICD-9 codes to identify these patients for both venous thromboembolism, IVC filter insertion, more advanced therapies, and unstable patients by probing things like shock or ventilator dependent. And then subjects were matched according to stability DVT diagnosis and thrombolytic therapy. And what they found was that as the patients became more unstable, those that had an IVC filter had a lower rate of in-hospital case fatality. 35% in patients who were unstable and did not receive lytics, with a number needed to treat of 5. Now, obviously, this is retrospective data, so you can't draw any hard conclusions. But I think it's important to consider that maybe there are some patients in whom we would use this who have poor cardiopulmonary reserve on a case-by-case basis. Other outstanding questions that I think we don't have good evidence for, what about prophylaxis in patients at high risk for thrombosis and bleeding, like our neurosurgical patients or trauma patients? Well, the CHEST guidelines are against this recommendation, whereas SIR and ACR are in support of this. Some retrospective data suggests that maybe it does benefit, but again, it's weak evidence and we don't have a lot of good data. And in patients with recurrent thromboembolism despite therapeutic anticoagulation, I would recommend adjustment of anticoagulation first before you think about putting in an IVC filter. So if your patient's on Coumadin, you should try them on heparin, low molecular weight heparin. If they're on low molecular weight heparin, you may want to titrate the dose, the weight-based dose, before you think about putting in an IVC filter, because those are thrombogenic devices as well, as you know. I'll finish with just a case example. So this was a 43-year-old that I saw who had had a bicycle accident 15 years ago, resulting in a spinal cord injury, and who was coming in for evaluation of IVC filter extraction that had been placed prophylactically at the time of his accident. He saw some infomercials on TV, saw info about complications, and wants the filter out. He's ambulatory, he has mild right-sided deficit from his injury, and he's never had a venous thromboembolic event. So going into the coronal view of a CT angiogram, and what you can start to see is here's the filter perforating into the aorta, and then across into the renal vein and up into the liver, and it actually was abutting the vertebrae as well. So for that particular patient, I had him see both IR and vascular surgery, and collectively we made a decision to leave the filter in and monitor him because it was going to be too difficult to get out, probably. So I'll leave you with some parting thoughts. The only indisputable indication for IVC filter implantation in 2019 is a contraindication to anticoagulation. The remaining cases that you're thinking about it, like your patients with poor cardiopulmonary reserve, should be assessed on a case-by-case basis and probably with multidisciplinary input. And if you put a filter in, get the filter out as soon as possible. Finally, I'm going to quote Dr. Fishman from yesterday's session: the best way to prevent IVC filter complications is to avoid putting one in. Thank you.